I'm a gynecologist, obstetrician. I'm founder of this hospital. I've been there since it was started. I work hard, I just deliver babies. I'm a delivery boy. I came back from England being a specialist. I had no access to especially private hospital services. So we had to build our own hospital. You know, those days are apartheid days. Patients were allowed in the private hospital, but I was not allowed to go and see the patients there. So I was disadvantaged in that way. And the old visionary doctors like Dr. Mutlana, Dr. Mokhesi, thought of an idea of having a black hospital. That's about 30 years ago. And this hospital, they went looking for money and they built the hospital. It has been flourishing since then. There are people who didn't believe that a private hospital could start. But there was one particular doctor, I must mention him, Dr. Mutlana. He had that vision that one day things will change. It has been expanded by clinician Dr. Matsike to what it is today. It's one of the best hospitals in Johannesburg. Now there's an avalanche of black doctors of all disciplines. I'm vindicated, I feel vindicated, I'm excited about that. There's more staff, there's more nurses, and it's a happy environment. High-class theaters, second to none in this country. You need to have special facilities for black people here. So this place grew, they saw the potential of this place. It can still, it has a capacity, of serving a community of 4 million people. It hasn't reached its capacity yet.
Good evening, colleagues, and once more welcome to our next session that we have with you at Clinics Health Group as we continue with our endeavor to bring medical education to our communities, to our colleagues within the private sector and the public sector, hosted by Clinics Health Group. And once more this evening, we are continuing with this endeavor that we started in 2020 during the hard lockdown when we are all had to stay home. Well, I know that practitioners, people like you, couldn't stay home because you had to look after patients during the difficult times of the pandemic when we didn't know what had hit us, and we all survived. But we know that some of our colleagues succumbed to COVID-19, and we honor those of friends and colleagues, family members who succumbed to COVID-19. And as we know that COVID-19 changed the way we do things, and we are able now to bring this webinars to you every Thursday evening, live on Zoom, and now we are also live on YouTube. So we just want to thank all of you for coming in every week to partner with us as we bring you a variety of speakers who come from different fields in our healthcare industry, specialists in their own right from various disciplines. And once more this evening, we have that opportunity again to do that. And as you log in, we also request that you make sure that you mute yourselves so that we have no interference during the presentations. Also switch off your video. Mine is still on, so that at least you can see who I am, and so that when we speak to you also you can recognize some of the faces that you see. But later on, we'll switch off my video and we request that you do the same. This is a CPD accredited webinar. And so every one of you who is registered, please make sure that you submit your information about yourselves, your name, surname, your registration number with the HPCSA. Majority of you here, I think, are from the HPCSA. But if you are from a different profession, regulatory body, please also indicate that and give your registration number. We'll share that with the CPD organizers for us And those who are with the HPCSA, your information will be uploaded and you'll get your certificates or you'll get your TPD points sent straight to the HPCSA. So you don't have to worry about that. Your points will be updated. And so this evening, we have a great pleasure of welcoming amongst us one of the elders in our medical profession, Professor Joe Veriava, who has been part of this journey since we started, and also a close associate within Clinics Health Group, who serves on our clinical risk committee, assisting us in making sure that we provide quality health care for all patients who come to our facilities. So this evening, Professor Veriava will be speaking on generic medicines, ethical and legal use. I do not have to do much of an introduction for Professor Joe Veriava, who is a specialist physician and a certified nephrologist. He has worked a lot within the healthcare industry. He's been a member of the Helen Joseph Hospital as the head of Department in Medicine and also head of nephrology associated with Wits University as head of department, and also involved with many other sectors within the health industry, and a recipient of one of the prestigious awards that you can imagine in the country, the Lutwil Award, and also has been associated with the Steve Biko School of Bioethics. And so we just want to welcome the recipient of the Order of Lutwil Silver, Professor Joe Veriava, to speak to us this evening. And we hope, and we know that we're going to have a good talk, as he's one of the best that we have within the medical profession. Prof, we welcome, and thanks for joining us once more.
I've unmuted you.
You've unmuted me. Okay. Dr. Billa and colleagues, good evening. An apology to many of our cricket fans because the match is still on. However, at the outset, I would like to thank the clinic's management for having set up these CMEs on a regular weekly basis, and also to provide me or give me an opportunity to make a presentation to you this evening. My topic for this evening, sorry, it's not moving.
Hi, Prof. This is Kamu. Can you click on the slide and try to... Thank you.
Okay. Now, the topic that I'm going to be presenting is that of generic medicines and the ethical as well as the legal issues that relate to it. And as you are aware, medical ethics is a system of moral principles that apply values and judgment to the practice of medicine. Now, there are various ethical principles. These are the conventional ones, such as autonomy, beneficence, maleficence, or non-maleficence, and then finally justice. And the first three, autonomy, beneficence, and non-maleficence, really in relation to the generics are something, these are the principles that are of importance in your doctor-patient interaction and also doctor-patient relationship. Justice on the whole is relevant throughout. However, it has a special sort of value when it comes to communities, and that is where we would in fact focus on justice. Now, As to the legal aspects, there are in fact the SAHPRA, which is the South African Health Products Regulatory Authority, which has the responsibility to license generic medicines. And previously, up to I think 2018, it was referred to as the Medical Control Council. Now, SAHPRA has 3 essential pillars, and these pillars are there to ensure that medicine, medical devices, etc., meet the requisite standards to protect the health and well-being of South Africa. And the 3 pillars of safety, efficacy, and quality ensures that the use of generic medicines would be worthwhile, if you want to call it that, or to say that generic medicines, in licensing them, are in fact one could be confident that they could be used with safety and also these being effective. Now, my presentation will cover the following areas. First of all, the generic medicines concepts that I will put across. Then the regulatory requirements for registration of medicines. Then the affordability and access to healthcare, comparative costs, usage, prescribing generic, and case history, particularly that relating to access to antiretrovirals during the HIV epidemic. Now, a generic drug is a drug defined as a drug product that is comparable to a brand reference listed drug product in dosage form, in strength, in quality, and performance characteristics, and also intended use. A generic medicine is considered to be biosimilar or bioequivalent to the originator medicine if the rate and extent of absorption of the active ingredient following the administration of the medicine do not show significant difference from that of the originator medicine for the registration of a generic medicine by SAHPRA, or what was previously the MCC. Generic companies must conduct bioequivalent study to prove that the active ingredient of the generic is comparable to the blood concentration of the originator medicine at any given time after taking the medicine until it has been eliminated from the body. While the active pharmaceutical ingredient does not differ between the originator and the generic medicine, others are inactive ingredients, and the term for that is an excipient. These may be different. Where these other ingredients are different, there may be a potential for the generic formulation to cause problems. It is incumbent on prescribing physician to remain vigilant to the potential risk and exercise caution in the substitution of a medication with the equivalent. Now, the requirements are as follows: that there should be adequate mechanisms to provide certainty that the generic medicines are of assured quality. Functioning and transparent medicines require regulatory agency. This is fundamental. Systems that facilitate market entry of generics. Now, SAHPRA requirements for the registration of a generic medicine is, first of all, that it should be or have the same quality, safety, and efficacy as the originator medicine. Now, SAHPRA doesn't test for safety and efficacy. So the test for safety and efficacy is by the pharmaceutical companies who conduct these studies when the medication is prepared. And clearly, the essential tests that they conduct is that to satisfy the requirements of safety and efficacy. So the SAHPRA also requires that they should be a similar bioequivalent to the originator medicine. Post-registration testing and assurance of maintained stability, enhanced quality, safety, and efficacy over the entire shelf life period of the product. So these are the requirements of a generic. Now, in the in relation to the right to health care, Section 27 of our Constitution has in fact established that everyone has the right to have access to healthcare services, including reproductive health care, sufficient food, and water. But what I want to emphasize at this stage is this bullet point, which says that the state must take reasonable legislative and other measures within its available resources to achieve the progressive realization of each of these rights. And I'll come back to this later when I sort of focus on the struggle to try to get antiretrovirals being manufactured in South Africa. An important element towards the realization of this right, as well as the ethical principle, is affordability. Now, affordability towards various elements involved in healthcare delivery facilitate the access towards such elements of health services. Affordability of the cost of medicine, when required for the cure of illness, is consequently an important component in access to healthcare. Access to healthcare service relates directly to individuals or indirectly to communities. Now, the World Health Organization has, in fact, a list of essential medicines. Now, these essential medications are those that satisfy the needs of the population and to which all people should have access at all times. 30% of the world population does not have access to these essential medications. And the poorer the country, the larger the proportion of health budget is required to fund medication. In developing countries, the proportion spent on medication is estimated at between 25 to 66%. Sorry, just excuse me, there's something on my screen that's problematic.
What's wrong?
I can't see the top one.
What do you want?
I want it out then.
This part. Oh.
No, this whole line here. Okay. Thank you. Sorry about that. Now, this slide relates to distributing health resources equitably and fairly. And this component or this element of this relates to the aspect of justice in terms of our system of the health system efficiency relates to an optimally functioning healthcare system. The World Health Organization report of 2010 concluded that 20 to 40% of all health spending is wasted, impacting on global access to healthcare. Of the 10 leading causes, the top 3 relate to medicine use, namely underuse of generic medications or paying higher than necessary prices for medicine. The lower cost of generic medicines may, however, be associated with the retention of quality as it impacts on the efficacy and safety demonstrated in the originator medicine. Hence, the need for the healthcare provider to be assured of the retention of such quality. Now, coming to the healthcare cost in the private sector, these costs were done a while back, so and they're probably different now. One noticed that in the private sector, medicines account for 16% of the expenditure. What is of interest is that medical specialists constitute 24.5% of the benefits paid out by medical aids. Also, the general practitioner only gets 7% of the total benefits paid out. And I think that this is problematic. Clearly, the general practitioners are the first line of a healthcare visit by most patients. And this should be a lot more, but unfortunately, lots of individuals go directly to the medical specialist. The medicine account for 16% of the total benefits paid out. In the public sector, the major cost is staffing cost, which is around about 17%. And goods and services such as pharmaceutical and other therapeutic agents are also quite high. I don't have the figure for those, but my personal feeling is that in terms of percentage, this is probably lower than that in the private sector. Now, the cost of antibiotics in Africa, just as an example, is that when ciprofloxacin came out earlier, the cost for a whole course of ciprofloxacin cost $45.37. And the generic, when it came, cost only $3.22. So there's quite a marked difference in cost between the brand ciproflox and the generic. And then looking at certain of these agents or medications for hypertension, looking at an ACE inhibitor, perindopril, we noticed that if the generic, the savings in terms of RAND for a month supply is 64.37 RAND. Valsartan, 127.12, that's the savings. And amlodipine, which is very commonly, fairly commonly used, is about 162.5 Rand. So clearly there are significant differences, and using generics does bring about considerable savings. Now, with the cost of healthcare rising, all parties involved in delivery of healthcare need to work to reduce costs while continuing to provide quality care to our patients. In relation to the prescription trends, the top 5 therapeutic groups ranked according to contribution to total expenditure are, firstly, antihypertensives, which is 11%, cytotoxics, 6.3%, although cytotoxics are quite expensive, much more expensive than those antihypertensive. Anti-diabetics, 5.8%, antidepressants, 4.4%, and gastric acid reducing agents, 4.3%. So in order to practice cost containment, use of generic medicine is one of the methods of cost containment. Use of medical medicine formularies is the other, and avoid polypharmacy by prescribing only medicines indicated for the clinical condition. And polypharmacy, whether it's the private sector or the public sector, is often a wastage of financial resources. Now, and just to go back to the brand medicine and the problems that are associated with the development of these brand medicines or a new drug that has to be developed. First of all, they need to identify a chemical or molecule with a desired effect. For instance, in our COVID environment, the drugs that had to be developed were those that would prevent the replication of the virus. Secondly, they have to show that the chemical or molecule can be manufactured in large amounts to not only test it in drug trials, but also able to sell it, commercialize, and this is the commercialization phase of the development portion, research and development. There has to also demonstrate safety by testing in animals during the early phases, then demonstrate efficacy in animals, and then demonstrate safety in humans by testing in healthy people. And finally, demonstrate efficacy and safety in patients. And this whole process in the development of the brand medicine takes from 15 to 20 years, and it is extremely costly. And this diagram here just puts what happens during the period of patent, and that is, during this period, there's market exclusivity for brand name products. And during this period, the pharmaceutical company that developed the drug would recoup the cost of bringing drugs to the market or the drug to the market, and then would have the time of probably, it's about 20 years of patent protection, and also finally that the money that is accrued during this period would be incentivizing innovation for further drug development. But during this period also, it may happen in many countries that there's a personal importation of unapproved generics. And this results in excuse me, quality control issues, undermining intellectual property regimes, de-incentivizing innovation, and undermining regulatory authority. At the end of this 20-year period, you have the approved generics enter the market. The one aspect of this generics entering the market is that the brand name product, there will be that may have a price reduction to stay competitive in the light of these generics entering the market. But these generics, as we mentioned earlier, have to satisfy bioequivalence issues, increase healthcare system efficiency, and there's loss of market share by the research and development pharmaceutical companies. Now, there is still a significant reluctance to use generics. There are many reasons for that. One is that people get accustomed to brand loyalty. During the patent period, the commence using a certain product. And once the patent expires and generics come out, they've already developed a habit of just continuing with the brand product. There's also distrust of generic companies. There's distrust of regulatory authorities. And also, there are perverse incentives not to change. And pharmaceutical companies do, in fact, give some benefits to individuals who continue prescribing their products. And finally, there is many people or many doctors believe that there is evidence of genetic inferiority. Now, this is something that should not occur. We would not have genetic inferiority if we have credible regulatory authorities. So this is anecdotal, and there is no evidence that generics that are developed and licensed by regulatory authority or credible regulatory authorities are inferior. There are sometimes problems where certain products may not have the bioequivalence and other characteristics that are required by credible regulatory authorities. An example of this is when there were when macrolides were evaluated, and there was an evaluation of 65 generic clarithromycin from 18 countries. Sorry, excuse me. And 9% failed to contain between 95 to 100% of clarithromycin claimed on label. And then 34% released less drug. 19% exceeded the Abbott Labs 3% limit for impurities. However, there has been a much larger study that showed no difference in outcome in community-acquired pneumonia. In other words, that the brand product compared to the generic had similar outcomes when tested again in patients with acquired pneumonia. sorry. Now, generic CEFTRIAXONE, the comparison of pharmaceutical quality of 34 of CEFTRIAXONE with Rosafen, international quality standards violated on 18 occasions. So there are these problematic pharmaceutical agents because of the bioequivalence or the quality may differ. But these are really related to inadequate quality control or inadequate testing by the regulatory authority. Locally, in our country, in vitro activity of cefotaxime, cefuroxime, cefzolan, and cefotaxetine supplied by Aspen and Pharmcare was compared with Rosafen, Zinasef, Cefzol, and Mifoxen. And the generics were comparable to the innovative drugs. Now, is there a clear relationship between bioequivalence and the drug's therapeutic efficacy and tolerance? There has been, however, debate about drugs with narrow therapeutic range. For example, anti-epileptic drugs and warfarin, and highly specific drugs such as immunosuppressants. So it's not in all instances that bioequivalence and the drug's therapeutic effect and tolerability would be, there would be a clear relations. However, the drugs that are, sorry, before I go on to that, the clinical effects of generics, a systematic review of 47 studies that compared cardiovascular drugs found no evidence that brand name drugs were superior with respect to clinical outcomes. And a randomized controlled trial comparing a brand antibiotic versus generic antibiotic found no difference in the clinical effects. Retrospective case control studies with anti-epileptic drugs yield some data suggestive of therapeutic inequivalence. But the issue that is now prominent is that the rate of generic substitution has increased for both acute and chronic drugs. From 2008 up to 2014, there was a gradual increase in the prescribing of, in fact, generic drugs. Initially, 51.8% chronic requiring or chronic drugs for chronic illnesses, and 58.3% for acute clinical problems, and it all increased to from 51.8 to 77.1, and for acute 58.3 to 72.4. When not to substitute to generic? First of all, if the patient refuses, and that relates to the principle of patient autonomy. Where the prescriber or the doctor writes no substitute, where the generic is more expensive, and this is obvious, and medication declared non-substitutable by SAHPRA. Now, agents with a narrow therapeutic range are not substitutable. Known agents which are known to have erratic intra and interpatient responses, likely to give significant bioavailability problems, such as those agents that are extended or have an extended or delayed release preparations. These cannot be substituted. In critically ill patients, geriatric or elderly patients, it may be safer to use the brand product. Now, what is not substitutable? First of all, anti-epileptic, because they have a narrow therapeutic margin. Digoxin, not many people are using digoxin these days. Furosemide, various combination antihypertensive, for instance, such as antihypertensive that has an ACE inhibitor and a diuretic. Hydrocortisone tablets, prednisolone tablets, and warfarin sodium tablets. These are not substitutable. Patient compliance enforcement and high cost of originator or brand medicine have the potential to decrease access to many who need these medicines. At what point is the financial burden on the patient more important than the patent protection of the high cost of drugs? While the patent system has worked well in development of medicine, it is in many instances based on market demand rather than consumer need. As a consequence, it often results in no medicine being developed for most diseases of the poor because there is no financial incentive to develop products for low profit or no profit market. And this is, for instance, drug development for tuberculosis. Now, is it possible? Are there measures to ensure the supply of cheaper medicine? And Section 15C of the Medicine Act allows the Minister of Health to take action that results in the supply of cheap medicines by passing regulations that protect the health of public. And this is where early on, our government failed patients who had, or during the patients who were suffering from HIV early in the pandemic. So one would have expected the Minister of Health to, in fact, promote the development of local manufacture of generic medicines. And paragraph A appears to give the minister very wide powers to override exclusive rights of patients. So under certain circumstances, we could have manufactured generics, particularly when we were in the midst of the HIV epidemic. That would have, in fact, saved many lives. Paragraph B also deals with parallel imports, and Section 8 and 9 of the Competition Act recognizes the following abuses that are relevant to access to medicine. Excess pricing that cannot be objectively justified, refusing to license generic manufacturers, and engaging in prohibited price discrimination. There's the other sort of area is Section 27 of our Constitution. And in that area, or according to the Constitution, the state must take reasonable legislative and other measures within its available resources to achieve the progressive realization of each of these rights. That means the right to health care. And this would also have favored the government to allow the development of generic HIV medications. Now, in 2001, the Pharmaceutical Association of South Africa and 39 pharmaceutical companies, in fact, wanted or had a lawsuit against the South African government that to try to prevent the South African government from going ahead and either importing generic medicines or in fact manufacture generic medicines. However, the drug companies agreed to accept virtually all of the legislation under the agreement, so South Africa would comply with the rules of the World Trade. And this was due to a lot of activism that was going on. Now, in relation, and I think the case that I would like to put across is the access to antiretroviral medications and the challenges that were there. It was clear during the early phases that there was reluctance to get or treat patients with HIV with antiretroviral medications. And this was the government not prepared to, in fact, fund and as well as the Department of Health providing antiretroviral medications. This was because of peculiar views that were present among the highest level of the Department of Government. And secondly, the drugs themselves were extremely expensive. So most of the poor could not afford that. And most of the people that were affected by HIV were in fact the poorer of the people of South Africa. What did happen was the Treatment Action Campaign was launched in 1998, and it in fact functioned between 1998 and 2008. And Treatment Action Campaign had activists who were really committed to the issue of human rights. And they, under the leadership of an individual, Zaki Ahmed, went about mobilization of people to campaign for the right to health using a combination of human rights education, HIV treatment, literacy, and very importantly, litigation. In 2002, the Treatment Action Committee and a range of individuals laid a complaint against GlaxoSmithKline and Boehringer Ingelheim, alleging that they were abusing their market dominance by charging excessive prices for their patent antiretroviral medicine. The Competition Commission investigated the case and found solid evidence to support the complaint. In order to avoid a final legal decision on this issue, the two pharmaceutical companies entered into an out-of-court settlement with the complainants. They agreed to license generic competitors to manufacture and or import antiretroviral medicines and to sell these medicines that were manufactured locally throughout most of Africa. And the treatment action campaign's achievements were remarkable. Just to list these, first of all, the TAC between 2001 and 2002 had embarked on a national program for the prevention of mother-to-child HIV transmission, and this was launched. The campaign was launched and was the court, in fact, ruled in favor of the applicants. The Minister of Health, in fact, appealed against that, but lost the appeal. So this was a significant achievement, and in fact, it prevented thousands of children to be born whose mother was infected with HIV. The children did not contract the HIV. In 2004, for access to the implementation of ARE antiretroviral rollout within the operational plan on comprehensive treatment care and support. Defend the Medicines Act against individuals such as wealthy industrialists, Matthias Raff, who denounced antiretroviral treatment and instead marketed his vitamin pills as therapy for HIV. The Competition Commission found Glaxo and Boehringer abusing their market dominance, resulting in an out-of-court settlement. And it is clear then that the Treatment Action Committee contributed to the prevention of hundreds of thousands of deaths, particularly among the poor people of South Africa. I thought also that the present pandemic, just make a point or two on vaccine nationalism. And vaccine nationalism is an economic strategy to hoard vaccines from manufacturers and increase supply in their own country. High-income countries put their money in beforehand for many vaccine stocks, which hinders the manufacturer's ability to supply globally. This is in contravention of promises of equitable supply of vaccines amongst low and middle income countries, and it appears that it is not to aid the ailing humanity at minimum cost, but to sell their products to other countries at great profit. Now, vaccine nationalism, as most of you are aware, perpetuates a long history of powerful countries securing vaccines and therapeutics at the expense of the less well country. And wealthy countries do have a critical interest assisting global vaccination, and uncoordinated patchwork of immunity could exacerbate the rise of escape variants that could alter vaccine effectiveness. What has come out positively, and this is probably because of the global sort of criticism of the patent laws that prevented these being produced in other countries. The positive aspect of the criticisms of the existing companies as well as the United States is that Aspen was allowed now by Johnson & Johnson, and that Johnson & Johnson vaccine could now be manufactured by Aspen in South Africa. And there are 31 million doses for us in South Africa and 240 million to the rest of Africa. So now, despite the patent, there has been agreement that these vaccines could be produced, the J&J could be. Also, the BioVac, a local company, are now being prepared to produce the messenger RNA vaccine. And to support South Africa and African continent, to increase vaccine manufacture capacity in South Africa and across the African continent. And there are 100 million doses of the Pfizer BioNTech anti-COVID-19 vaccine that's going to be produced. So in conclusion, affordability of medicine is an essential element in the provision of healthcare to a patient and to communities. And this is in line with the principle of justice. Judicious use of generic medicines facilitates cost containment in the provision of healthcare. That's beneficence. The health practitioner must be aware of the SAHPRA requirements for the registration of generic medicines and when not to substitute for the brand product, maleficence. The prescribing of generic medicine to a patient must be consistent with the ethical principle of beneficence, maleficence, and patient autonomy. The need to communicate, the need of communities under special circumstances takes precedence over absolute patent protection. And this was clearly evident with the anti-retrovirals during the HIV epidemic, vaccine manufacturing during the infection epidemic, strict adherence or enforcing patient protection during global disasters is immoral. Thank you. And this is just that if you want to go into this matter any further, these are the bits of recommended reading.
Thank you very much, Prof. Veriava, for this interesting presentation and taking us back to the days of activism to get medicines for all those who deserve to get medicines in the public health system, and the fight that ensued during those early days, and also taking us back to the time for the treatment action campaign for the anti-retroviral pills or the medication to be made available during the beginning of that epidemic of HIV, and now also bring us back to where we are now with the pandemic, with the same problems that we're encountering with the rich countries hoarding vaccines for themselves, and that we in the third world struggling to get the vaccines that we saw required to stem the tide of this pandemic. I've seen some questions that have been posted, and One of them does take us to the issues of HIV. Dr. Hopa, that I'll start with that one first, because that's where you ended. And he wants to talk about that you should comment on the generic life-saving drugs like the ARVs that you've seen a rapid increase of such in recent times. Any comments?
Sorry, I didn't get that. What about the ARVs?
Yeah, he says that they comment on the generic life-saving drugs like ARVs, as we've seen in a rapid increase of such in recent times that Dr. Mohopa is alluding to. Yeah, maybe he didn't phrase it well. Dr. Mohopa, maybe if you can just maybe unmute yourself.
Clearly, there are two sort of sources of cheaper drugs. First of all, the price of antiretroviral drugs by the companies that were producing them went down. In fact, the prices, they decreased their prices. Secondly, there were now various countries that were also producing antiretrovirals. One of the first country was Brazil, that produced generic ones. And so the antiretrovirals at the present moment, where they come from, I can't comment because I don't know. But clearly, there are generic antiretrovirals, and these generic antiretrovirals would go through SAHPRA, so they would be effective and safe.
Yeah, you in your presentation, because I'm looking at the next question. You're painting a picture of where the health expenditure is, showing that you know the hospital groups or hospitals, that's where the bulk of the expenditure is, and secondly the specialists, and then thirdly it's the medication, the drugs. And this question says now we're looking at the dispensing of drugs. Is it ethically correct for the medical aids to charge patients a huge amount of levies when they choose an ethical product over the generic product?
I think that first of all, the various what shall we say that the various suppliers or whatever would have their formularies, and these formularies in fact include or are primarily for generic drugs or generic
medicines, yeah.
And they do that, but the doctors in discussion with the patient can in fact decide to use brand product, but then there would be a co-payment with that. So my personal feeling about this is that the generic being equal in terms of efficacy and safety, particularly in our setup here in South Africa, I don't think there should be a problem about it.
So we shouldn't worry about the generic use because the efficacy is almost the same as the originator drug?
It is the same. So if it is the same, there should not be a problem that medical aid company would say, use the generic. It's cheaper, and the medical aids also are there to try to save money or to bring down the cost of medications, and that is something that's a reality.
Okay, so what you're saying, Prof, is that the take-home message is that any physician, any doctor, or GP in the private rooms, they should be comfortable that them using generic medicines is quite a safer route, and also it's also cost effective, and that there shouldn't be any worries about whether the drug works or not.
Yeah, that's exactly what I think. And I have been using generics, even on myself.
Yeah, well, once I went to a pharmacy, and one of the pharmacists was quite amazed when he was giving me a choice, and I also chose to go for a generic, and was surprised that it's good for a doctor. I mean, it's quite a pattern that a doctor would then opt for a generic rather than the originator. So, I mean, what you're saying is that we should be comfortable with it.
Yes.
Okay, there's the next question from Dr. Mashadi. No, I'm not sure. She wants to know about Cresta versus simvastatin. Your comments on that?
Sorry.
Cresta, I'm not, I'm out of clinical practice. I don't know. Cresta versus simvastatin. It must be one of the ethicals.
Yeah.
You want to go, Dr. Mashadi? Maybe.
I don't know much about that, whether there is a generic, and so I can't comment on that one, unfortunately.
Oh, okay. No, thank you very much. Are there any questions, colleagues? Anyone who still has a question for Professor Veriava? And I think from this interesting discussion that we've had this evening. I think you covered quite a lot this evening, and also take us back to the vaccines. But my while, you spoke about that the richer, the first world countries were hoarding the vaccines, and we had our own plants manufacturing J&J. But the reports that we're getting is that there are a lot of drugs that are still sitting in the warehouse there. And even the government is not ordering new vaccines, because there are not many people in the country now who are taking vaccines. So would you say that maybe on one hand we were clamoring for more vaccines, but at the same time that the public is not coming forward to get the vaccines? Any comments?
Yeah. Well, I think that has been, the whole issue of vaccine hesitancy is what you're referring to, I think. That and vaccines are not being utilized maximally. So to go back to saying that we were, and I'm just trying to understand whether feel that the producing the biotech or the Pfizer vaccine here and the J&J vaccine here is probably not worthwhile. Is that what you're trying to?
Yeah. Yeah, but there's a big chance that we may have to destroy quite thousands of vaccines because of that hesitancy. The government is trying very hard to encourage the public to get vaccines, and I'm not certain how many of our colleagues here have gone for their booster doses. So there's also questions about the vaccines. There's a question if COVID vaccines are moving very slowly at our site at present. Well, I think that's common. It's almost everywhere. The numbers have just gone down, and it's a bit difficult to get the public getting vaccinated. You've not reached the targets that government had set for itself to get 70% of the population vaccinated by this time. Are they? Yeah.
I'd just like to going back to the one slide. And I'll just see that.
Okay.
This slide here.
Yes.
What is of importance there is the fact that it's also these vaccines that are going to be produced here is not only for South Africa. You notice that a lot of these are also for the rest of Africa. So
Yes.
I think that's a positive aspect. But most of Africa, there is, in fact, it's not due to vaccine hesitancy that they're not there. It's just they don't have the vaccine. So clearly, if we're going to be producing these vaccines here in South Africa, it will benefit the continent.
Yeah.
Though we may be wasting those vials, whatever that we have.
Definitely, yeah. But the fear is that the rest of Africa is not even placing orders for these vaccines. So that's why the Aspen plant is about to shut down, because they are not going to be continuing to produce more vaccines. But I think that's a topic for another day. I see that we have no further questions and most of the colleagues are now logging off. I'm going to ask Dr. Kinochi, who's our Chief of Operations, to do the closing remarks. Dr. Kinochi.
Thank you very much, Dr. Bila. Let me just thank Professor Yosuf Veriava, commonly known as Dr. Professor Joe Veriava, known for in the profession by generations, actually, Prof, of people that you have taught. You are an esteemed physician and an academic and a renowned teacher. And we've learned a lot from you over the decades. And I think tonight was not different. You've taken us back as healthcare professionals to the need to think about what we are prescribing, because I think we might forget in the busy world that we work in to know that whether we are prescribing an original brand product or a generic, and also the differences. You've told us about the differences in costs, and that there might be differences in ingredients and quality, but that's minor. I think we are fortunate in South Africa, as you pointed out, that we have SAHPRA. So we can be confident that the generics that we use in the country, which are SAHPRA approved, are of good quality. And I think it's something that you have reminded us about, and we should have confidence in it. I think you've also told us about the history of generic substitution in the country, quite interesting, and also the politics of pharmaceutical industry in the country. I think it was a great talk. Really appreciate it, and I'm sure our audience did as well. I think your slides will be available. Anyone who needs a copy of the slides can contact us in clinics using the same email addresses that you were given as when you are registering, and we will send you a copy. But I would also, it's not every day, Prof, that we are addressed by a recipient of the Order of Luthuli in silver. And I think we are proud of you having given us your evening tonight. Let me thank all the healthcare professionals who took time to log in today. And I think please do log in. The webinars by clinics are free, as Dr. Bila always reminds people. And please register using all the information that you are required to provide when you register, because that enables us to make sure that your CPD points that you gain from attending these webinars are automatically loaded on your profile with the HPCSA on a weekly basis. Thank you very much for having logged in. I think today we had about 250 at one stage, which is quite a big number. We need to thank you, Dr. Bila. I call you our webinar master because I really, because of the astute way in which you present these webinars every week. I think non-tiring energy that you got. I think thank you very much for providing us with the webinars on a weekly basis. I need to thank our marketing and communication team led by our Chief Marketing Officer, Ms. Matsepo Majola and her team. I think tonight they provide the technical service in the background, make sure that the webinars do happen. I think today that they are represented by Kamohelo Busekwe. Thank you very much. Let me hand over to you again, Dr. Bilal, for the closing.
Thanks a lot, Dr. Kinoshi, for those words, fine words. Just to inform the colleagues who are locked in tonight that next week, it's June 16th, so we won't be having a webinar, but we'll be back the following week, I think the 24th, where we'll have a young doctor who will be presenting on dermatology and skin conditions in teenagers. So please do log in and know that we won't be having this webinar next Thursday. And have a good evening. Thank you.
Thank you.
Thank you. Good night.